two beautiful countries in the world, India and Australia. This is eCritCare podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare podcast. This is our episode number 99, and I'm joined by my co-host, Dr. Jose Checco from India. Welcome, Dr. Checco.
Good evening, Swapnil. How are you?
I'm good, thank you. It's good to be back after a long time. Had a bit of break, I guess. So how's things in India now?
Things are pretty cool. We are not too overworked at this point of time. A lot of viral infections, many of them not COVID, non-COVID viral pneumonias have become pretty common these days. Few sick patients in ICU. So it looks like COVID has sort of settled down, but we are getting a lot of non-COVID viral infections, particularly H1N1.
Yeah, I guess similar situation, in many ICUs across the world that probably in winter here in Sydney. And I guess we are getting more viral infections not related to COVID. So pretty similar situation, I guess. So the controversy that we're going to discuss today is around temperature management in patients with traumatic brain injury. Now, this topic is quite interesting because traumatic brain injury remains the leading cause of increased morbidity and mortality across the world. The survivors of TBI often suffer from variable neurological deficits, including impaired memory, varying range of cognitive disturbances. And despite all the advances in treatment, TBI is a major public health problem, which constitutes for highest cause of morbidity and mortality across the world. Now, there are two mechanisms of TBI which lead to significant neurological damage. One is the primary injury, which we know occurs within the minutes of the trauma, and it is due to irreversible mechanical injury and can't be obviously modified. However, the secondary injury, which occurs due to cerebral edema resulting from either raised ICP, hypotension, hypoxia, anemia, seizures, hypoglycemia, and hyperthermia. And that's where the prevention and correction of the secondary brain injury with the management of temperature has a potential role in improving the survivorship of patients with TBI. And that's why the hypothermia was initially proposed to be one of the modifiable factor in patients with TBI. Now, I guess some of the physiological rationale behind hypothermia in TBI include it helps to reduce the cerebral edema by a suppression of excitatory amino acids, especially the glutamate, which decreases the calcium influx and stabilizes the blood-brain barrier. Also, it helps to decrease the reactive oxygen species like free radical-induced damage, which in turn reduces the lipid peroxidation and decreases the cerebral edema. And the third mechanism which was proposed was by decreasing the CMRO2 or overall consumption of oxygen by brain or decreasing the cerebral metabolic rate, and which again helps to decrease the cerebral edema. So there are various mechanisms were postulated in how hypothermia might be beneficial in patients with TBI. However, there are a lot of controversies still do exist in this topic. One of them is around selective brain cooling versus the whole body cooling. I guess because one of the things that we know that probably the brain temperature does not particularly correlate with our body core temperature and is often thought to be higher than body core temperature. And what target temperature should we be targeting in patients with TBI? Because there is no set target which has been studied extensively, which again showed any benefit with regards to patients with traumatic brain injury. And the third important controversy is regarding the total duration of targeted temperature management or therapeutic hypothermia in patients with TBI. Because again, first 24 hours, 48 hours, or 72 hours still remains a controversial issue in this topic. So Dr. Checco, can you walk us through what is the available evidence on this topic and how these different controversies have been addressed in the literature so far?
Ever since the use of hypothermia, even from very ancient times, as a neuroprotective intervention, there has been an interest mainly from the 1960s onwards in cooling down patients post-cardiac arrest. So the interest in hypothermia after traumatic brain injury really emanates from the evidence that we have from other types of ischemic brain injury, like post-cardiac arrest, stroke, raised intracranial pressure due to other causes, and so on. So it's in the light of this background that we need to look at the studies that have specifically looked at severe traumatic brain injury. One of the early studies was the study by Marion et al. In 1997, which looked at 82 patients, not a big number. These patients were sustained severe traumatic brain injury defined as a GCS of 3 to 7, and they were randomized to hypothermia for cooling to 33 degrees centigrade within 10 hours of injury, or to maintain normothermia. So they looked at the Glasgow outcome scores at various time intervals, and they came up with the finding that in patients who had a GCS of between 5 to 7, hypothermia resulted in significantly improved outcomes at 3 and 6 months, but the outcome improvement was not seen in more severe traumatic brain injury with a lower GCS of 3 to 4. So this was one of the first randomized controlled trials that really showed the potential for benefit with induced hypothermia in traumatic brain injury. Around this time, just a couple of years later, there were a few Chinese studies as well, Jiang et al. And Zhai et al. They also showed that induced hypothermia for variable periods of time between 33 to 35 degrees centigrade might improve neurological outcomes after severe traumatic brain injury. So at that point of time, things were a little bit unclear. We had some not very strong evidence that suggested improved clinical outcomes from cooling after severe traumatic brain injury. So this led to the National Acute Brain Injury Hypothermia, or the NABISH studies. The first one was published in 2001. This large randomized controlled trial included 392 patients with severe TBI with a GCS of 3 to 8 after resuscitation from 11 centers in the US. Patients were assigned to undergo hypothermia at 33 degrees centigrade, initiated within 6 hours of injury and maintained for 48 hours, while the control group received normothermia. Unfortunately, this study showed pretty poor outcomes, with 57% of patients in each group suffering severe disability, either in a vegetative state or resulting in death. Mortality was also similar. So this study did not show any difference between hypothermia of 33 versus normal temperature in 392 patients when hypothermia was induced within the first 6 hours after injury. So that was the Clifton 1 trial, or the NABISH-H1 trial of 2001. The second NABISH-H trial was published in 2011, and this was specifically meant to evaluate the benefit of early hypothermia. Remember, the NABISH-1 study looked at hypothermia induced within 6 hours. So the NABISH-H2 study induced hypothermia, or tried to induce hypothermia, within the first 2.5 hours of injury. So these patients were randomized to hypothermia, and they attained a temperature of 35 within 2.6 hours as planned, and they reached a temperature of 33 degrees centigrade within 4.4 hours. And this, of course, was compared with normothermia. But here again, unfortunately, disappointingly, the outcomes were poor in both groups, and there was no statistically significant difference in terms of adverse neurological outcomes between the two groups. Mortality was also similar between the two groups. So if anything, the NABISH-H1 and the NABISH-H2 trials both seem to confirm that neither a later initiation of hypothermia, which was after 6 hours, within 6 hours, or early initiation within the first 2.5 hours would result in improved neurological outcomes. The findings of this study was substantiated by the B-Hypo trial, which was the Japanese study, which again randomized patients in a 2-to-1 ratio, temperature 32 to 34 versus control of fever alone. And here again, they could not find any meaningful clinical benefit. So against this background, we had the Eurotherm 2015 study, Andrews et al., which randomized patients with raised intracranial pressure of more than 20 millimeters of mercury. And in cases wherein the intracranial pressure remained high despite level 1 interventions, including sedation and ventilation, they were assigned to hypothermia of 32 to 35 or just standard care. Level 2 interventions, including osmotherapy, were carried out in the control group to reduce ICP. In the hypothermia group, level 2 interventions were carried out only if hypothermia failed to reduce ICP. Here again, most disappointingly, the study was ceased halfway through due to safety concerns with poor neurological outcomes in the hypothermia group compared to the normothermia group. Favorable neurological outcomes were lower with hypothermia compared to controls, 26% versus 37%. And the authors concluded that among patients with intracranial hypertension of more than 20 millimeters of mercury, severe traumatic brain injury, therapeutic hypothermia does not improve the clinical outcomes. And then the latest in the run of randomized controlled trials is the POLAR study, which was published in the JAMA of 2018. They evaluated the effect of early prophylactic hypothermia after severe traumatic brain injury. This study randomized 266 patients to prophylactic hypothermia and 245 patients to just normothermia. So this was, by and large, the largest RCT so far on this topic. Prophylactic hypothermia involved early induction of hypothermia of 33 to 35 for at least 72 hours and up to 7 days if the ICP remained high, followed by gradual rewarming. Hypothermia was induced at a median of 1.8 hours, so that was pretty early. And rewarming was done in a very slow manner with using a median duration of 22.5 hours. So very slow rewarming was carried out in this study. In the control group, the temperature was maintained at 37 degrees centigrade. And the temperature in both groups was maintained in the normal range for up to 7 days. All other care was at the discretion of the treating physician. Favorable neurological outcomes at 6 months was the primary endpoint. And there was no difference between hypothermia versus normothermia, 48.8% versus 49.1%. The incidence of adverse events, including pneumonia and intracranial bleed, were also not different between the two groups. Thus, this study showed very early hypothermia within the first 1.8 hours did not improve clinical outcomes at 6 months compared to normothermia. So several randomized controlled trials, and in fact, a few meta-analyses have also looked at it. Some of the meta-analyses have come up with possible benefit, but the findings have been largely conflicting. And whatever strong, robust randomized controlled trials we have today seem to suggest that induced hypothermia following severe traumatic brain injury does not improve clinical outcomes.
Yeah, thanks, Dr. Chacko. So I guess that has reflected quite clearly in Brain Trauma Foundation guidelines in 4th edition that there was insufficient evidence to support any use of hypothermia in patients with severe TBI. Whether you kind of institute hypothermia early, that is less than 2.5 hours of admission, or short term, that is for 48 hours, there is no role for prophylactic hypothermia in these patients. Now, there is also a trial called as HOPES trial, which was conducted in patients with acute subdural hemorrhage. And again, that has also stopped early due to futility. So overall, the evidence so far, and especially the recent evidence with randomized controlled trial design, has gave us a clear signal, not in favor or against the use of prophylactic hypothermia in this subset of patients. It's suffice to say that probably we do not understand the overall role of temperature management in these patients at this stage, and all these postulated hypotheses how the hypothermia will able to control the ICP has kind of remained quite uncertain at this stage. And until that point, I guess it's better to avoid practicing prophylactic hypothermia in this subset of patients. We know probably fever is bad, and I think that's the kind of general consensus across most of the patients, whether it's a severe TBI or out-of-hospital cardiac arrest patients. So I guess preventing hyperthermia is the key. Having said that, inducing hypothermia is probably not the best idea in this subset of patients. So we do not practice hypothermia at all in Australian intensive care for patients with severe TBI. What's your practice has been there, Dr. Chakko?
We have in fact never really practiced induced hypothermia following traumatic brain injury. It reminds me that when I was working in Australia a long time ago, in one of the units, we did use therapeutic hypothermia for variable periods of time for up to 72 to 96 hours sometimes. Of course, there was no controls. We used to practice this at that time. But then when later studies like the NABISATE study found that there was no possible benefit, this practice was abandoned. So by and large, based on the evidence that we have today, I totally agree with what you said. There is no evidence to support the use of induced hypothermia in severe traumatic brain injury. And although there are several putative mechanisms by which hypothermia may ameliorate cerebral ischemia and injury, particularly in terms of reducing the pro-inflammatory response, inhibiting free radical release and excitatory amino acid release, none of these have really been shown to work out as in improving clinical outcomes. So considering the lack of robust evidence, we should probably confine therapeutic hypothermia to clinical trials and perhaps in patients with severe intracranial hypertension that remains refractory to conventional measures.
Yeah, and I guess we all acknowledge that the hypothermia is not without its own risk. And again, there are a lot of side effects of hypothermia, including, I guess, slowing the drug metabolism and drugs, a lot of the sedative agents hanging around, and also causing a lot of problems with electrolyte imbalances, hyperglycemia, or coagulopathy, and causing more bleeding. So all those problems are quite detrimental to patients, especially when there is no obvious benefit in practicing the intervention. So I guess so far the signal is very clear that do not use therapeutic hypothermia in these patients. Having said that, I guess one of the caveat for this is to make sure that we still practice targeted temperature management in patients with severe TBI, and to make sure that patients remain normothermic till we understand whether hyperthermia is really bad in this subset of patients. Because one of the drawbacks of not practicing targeted temperature management is that sometimes these patients start becoming hyperthermic or pyrexic, and people do not control the temperature. And then obviously we see the downside of the hyperthermia. So far it's suffice to say that there is no role for therapeutic hypothermia, but I guess practice the targeted temperature management, with targeted temperature being a normothermia.
That is very true, Swapnil. Very important to maintain normal temperature. Even mild degrees of fever might be harmful. So early recognition of fever and appropriate treatment directed towards control of fever is most important in traumatic brain injury.
Thanks, Dr. Chakko. So that's the end of our today's podcast. We will be back with another episode. That will be our 100th episode. So looking forward to that episode. And we are coming up with a textbook on critical care controversies soon. So stay tuned for that exciting piece of work.
Thanks, Swapnil. Thanks, everyone, for listening in. Looking forward to joining again for the 100th episode. And hopefully our book will be published pretty soon. So that will be very handy in terms of addressing the controversies that currently exist in the field of critical care medicine.
Thanks, Dr. Chakko.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.